these MR protocols is because it's very important in how well the actual O-RADS performs, because all of the research that was done around O-RADS really is dependent on how we run the protocol in order to get the results that we want, and especially the positive predictive value of the O-RADS risk stratification table. So we'll talk a lot about the different sequences that are used and how to use them properly or how to run them properly. And we'll do some cases on O-RADS MR as well, and just run through some take-home points as well. So for ovarian lesions, ultrasound obviously is the mainstay first-line tool that we use in radiology to evaluate them. They can diagnose benign lesions very well, and then you can also detect malignant or highly worrisome lesions as well too. It's kind of this middle ground where it's indeterminate, where it's the most challenging. I think that's where MRI is useful. MRI is very useful in evaluating the female pelvis, especially because it has high tissue contrast. It can differentiate between benign solid components versus enhancing solid tissue, which allows us to risk stratify that middle section where we may not be able to determine whether it's benign or malignant on ultrasound. And so this is the I'll move this out. This is the O-RADS table that you're all probably familiar with. And it goes from 0 to 5. 0 is incomplete evaluation, 1 is normal ovaries, all the way up to 5, which is high risk. And these are all associated with the positive predictive value of malignancy, from less than 0.5% to greater than or about 90% positive predictive value for malignancy. And so, for these PPV values to be true, it's really important to perform the right protocol. Otherwise, we may not be able to rely on the actual imaging to produce these PPVs. And I'm sure you've all looked through the O-RADS. So today we'll be mostly focusing on the techniques, and then we'll go over some cases as well. So just diving right into it, the hardware requirements. Most of you all have the clinical 1.5 Tesla or 3 Tesla. Either of them are okay to use. And then we also recommend a service body array coils. It's really important to have in order to boost the signal in the pelvis. So this is also on the ACR website, the MRI protocol. It goes through each of the sequences, the planes that are recommended, the minimum slice thickness, which is really important as well, because we don't want to lose certain features that may be small. And then there are also associated notes as well. This is really busy, so we'll go over most of these today in detail, but these are also available on the ACR O-RADS MRI website. So we'll first start into T2 weighted imaging. So this is our sequence that really allows us to look at the anatomy very carefully and accurately. So it has high spatial resolution, high tissue contrast, and it's also robust against susceptibility artifacts. So even if there is a hip implant or some other issue, gas in bowel, this is relatively resistant against susceptibility artifacts. So we're able to see what's going on in the pelvis the best in this sequence. They are longer sequences due to the long echo times that are required to produce these T2 sequences, but it's definitely worth it to have, and it's necessary to have in the evaluation of adnexal lesions. So for this, it's best to used for evaluating the origin of the adnexal mass or adnexal lesion. So sometimes it's hard to tell whether this is coming from the ovary or fallopian tube or even, sometimes large pedunculated fibroids can look like it's an adnexal lesion. So it's really nice to have this to look at the anatomy and to look at where the lesion is arising from, and that narrows down the differential diagnosis. It's also good for looking for lymph nodes and ascites as well, because this is a fluid-sensitive sequence. So it's really good at detecting where fluid is, which is usually bright. So for O-RADS, we really want a high resolution T2 turbo or fast spin echo without fat suppression. It's really important to have that fat be bright so that we have the tissue contrast. Otherwise, it's hard to tell the difference between the soft tissue versus the fat. And so you want to try to tailor your TE and TR to make sure that there's high signal in the urinary bladder and spinal canal. So high signal in the fluid. And so you could see that you could really visualize these tiny little papillary lesions, which are on the order of millimeter in size. So sometimes it's hard. Sometimes you get some artifact, and a lot of it has to do with motion because it is it's a longer sequence. In order to decrease motion, you can use some motion robust sequences such as blade or propeller, or there are also now AI or deep learning accelerated sequences. And because they're faster, there's less motion associated with it. So you could use that one as well, or placing saturation bands to decrease the breathing motion artifact. So these are some tips and tricks you can help to decrease motion artifact. You could tell like these little radial bands, that's all from breathing motion. But typically T2 has the least amount of artifact of your sequences. So moving on to T1 in and out of phase imaging. So this is also really important. This allows us to tell the difference between water and fat, both bulk fat and intravoxel fat. If you don't have in and out, you can also use the Dixon sequence, which also produces fat only, water only, or a combination of those. So this is an example of an in and out of phase sequence, and you can see that there's a left adnexal mass here, and on out of phase that drops out. So there's a lot of intravoxel fat in this lesion. So it's important to differentiate. It's important to have this so that you can differentiate other T1 hyperintense material like hemorrhage from fat. So again, it detects intravoxel fat as well as bulk fat. It is sensitive to susceptibility artifact, so you can tell where there's been hemosiderin or other surgical material if there's been prior surgeries, which may not be available in the patient's history when you're looking at the case. And also it's a very fast sequences. It's usually only requires a couple seconds to obtain. And this is really best for identifying fat, which can make the differential really clear. A benign lesion such as dermoids have the bulk fat. And they also actually have liquid fat. So if you see intravoxel fat, sometimes that's liquefied fat in the dermoid. So I know the teaching is most often that dermoids have bulk fat, but they can also have intravoxel fat, and that should indicate benignity as well, such as in this lesion here. So there's a dropout in fat. There's dropout in signal on the in phase and out of phase imaging, and that's, sorry, I think this is backwards. This should be out of phase and in phase here. But that indicates benignity. So O-RADS, it has to be 3 to 4 millimeter slice thickness in the axial plane. And then you could see the bulk fat as well as the other images. So on T2, this lesion is difficult to tell whether this is a fluid-filled cyst or some other lesion, but on in and out of phase, you clearly see that this is a bulk fat and a dermoid. And so some tips and tricks sometimes. So this is really a robust sequence, so you shouldn't really have too much trouble with running these sequences. But sometimes you can use 3D Dixon technique, which will save time if you're really looking for that, because it can help you with the T1 fat suppressed images as well. So that's also a sequence to consider using if you're looking to decrease time. Moving on to diffusion weighted imaging, which is helpful, and especially in ruling to determine these fibromas and fibrothecomas. That's really where diffusion weighted imaging is used officially in the O-RADS at this time. So it's really, it's a echoplanar sequence performed with multiple V values. And it's really important to have high B values. So we recommend at least having a B0, B50, and then also a B1000. You can usually acquire some middle B value, either B400 or B800 as well, to ensure that your ADC is nice. But it's really important to have this B1000 in order to suppress all the fluid signal in the bladder or cyst, to be able to look at these potential solid tissue in ovarian lesions. So even though officially DWI is really only used to look at fibromas, to diagnose fibromas or fibrothecomas, they're really helpful in detecting solid tissue as well. So, but in order to do that, it's important to have a high B value. And so these are the recommendations. So DWI axial plane is what we usually use, although you could always add a different plane if that's helpful to your circumstances. So it's important to have a 4 to 5 millimeter slice thickness in order to. It is a longer sequence, so I think T2 we actually recommend 3 millimeter slice thickness in order to visualize any small papillary projections. But because this is a longer sequence, 4 to 5 millimeters is okay. Again, it's really important to have a low B value and a high B value, B1000 to B1200, to make sure that the fluid signal drops out completely so that you can visualize these solid tissue components. So diffusion is really hard to optimize because they're often artifact. It's really susceptible to susceptibility artifact, such as from gas in the rectum or from any metallic implants that any patients may have. So, you could potentially change the frequency and phase encoding direction to help decrease, because all the artifacts are usually going in the direction of the phase encoding direction. So if you see that the artifact is propagating through whatever body part that you're interested in, you could move it. So like this artifact from the hip or metal implant in the right sacrum is propagating anteriorly, so it may be better to switch the phase encoding direction into the left-right or right-left, as opposed to anterior-posterior. Usually it is in the anterior-posterior direction because you want the phase encoding direction to be the shorter direction, just because that one is time dependent. Each line in the phase encoding direction increases the time of acquisition. So we try to decrease the time of acquisition by decreasing the width of, choosing the phase encoding direction to be the smaller distance that you're scanning through. So usually it's in the anterior-posterior direction as opposed to right-left or left-right. But in this case, it may be better to change that so that that artifact isn't propagating through any adnexal tissue there. Moving on to pre-contrast 3D T1 GRE, fat suppression, saturation or suppression. This is also very important. So this is for non-dynamic T1 weighted imaging. It's to really visualize bulk fat or macroscopic fat, and also to visualize any hemorrhage as well. So we use this in conjunction with the in and out of phase to really see whether something is hemorrhage or something is fat. So in this case, you could see this is all some on T2. There's this multicystic lesion on the top image here, adnexal mass, and on T1. It has different shadings, which are not as well appreciated on just the T2. So this is has different proteinaceous content in each of these loculations. So that's common for mucinous cyst adenoma. So you could base your differentials off of that. This is also a nice case where there was an adnexal lesion on the left and right, and then one ended up to be a dermoid here on the right because it subtracts out completely, suppresses out on the pre-T1 fat suppressed image as opposed to the in phase. And this lesion on the left here has persistently high signal on the non-fat suppressed and fat suppressed. So this was a hemorrhagic cyst or endometrioma. So that it just shows you the importance of having both non-fat suppressed and fat suppressed T1 sequences in the in your protocol. So for recommendations, this is usually done in the axial plane, although it's nice to have other planes. You can add other planes if you need to based on the adnexal mass that you have, 3 to 4 millimeter slice thickness. And if you only, for this, if you're not able to do dynamic contrast enhanced images, it's really important to have a post-contrast that's 30 to 40 seconds after contrast administration, and that's important to, that time point is really important because it'll allow us to restratify the lesions better. So this is an example. This is pre-contrast on the left here. You can see that there's some T1 hyperintensity nodules posteriorly in this adnexal lesion. Post-contrast, that is also persistently bright, and on subtraction, those subtract out. So those are just some either hemorrhagic or proteinaceous signal there. So it's important to also have the subtracted post as well if you do perform contrast enhanced sequences. So some of these also have artifacts, especially from non-fat suppression, non-uniform fat suppression, and you can change your pre-saturation pulse to reduce the fat signal, or adjust the TE to avoid peak lipid signal, or you can use Dixon sequence, like I mentioned before, in conjunction with to have the both in and out of phase type sequences and these fat suppressed. This is like the fat, water-only signals or water-only sequences. In addition, it's really important to maintain the patient within the center of the magnet in order to minimize effects of magnetic field inhomogeneities. So this is just an example of inhomogeneous fat suppression on the sides there. So for O-RADS, it's really important to have contrast enhancement in general. I think it's not, we really don't discuss it in this talk, but it's really important to tell the difference between solid tissue, solid enhancing tissue versus non-enhancing solid tissue or solid components. And that's really important to the risk stratification. You can really determine O-RADS 3, 4, and 5 based on that versus O-RADS 2, 1 or 2 lesion. In addition to that, more specifically, it's really important to have a dynamic contrast enhanced sequence. Without it, we can't really differentiate O-RADS 3 lesions versus 4 and 5. So it's really important to have O-RADS. I think part of the importance of MR is to determine which lesions are not as worrisome, such as the O-RADS 3 lesions, and to really identify those O-RADS 3 lesions, we need the dynamic contrast enhanced sequences, and that's why the DCE is so important. So this is really important on how we do it in order to get the best results as possible. So the dynamic contrast means that we acquire multiple different phases and not just the one phase. So we want to make sure we get a good baseline. So we usually acquire the first 1 or 2 phases before we administer contrast, so that we have a good baseline. And then the remaining the phases are acquired after contrast injection for at least 3 minutes in order to determine that 3 minutes, sometimes the phases, you don't really know the characterization of the kinetic curve or the time intensity curve until you have that 3 full minutes. Contrast should be administered at 2 cc's per second. That's also important. You don't want to inject too slowly or too fast. Too slowly, you may not get the rise in or characterize the arterial enhancement as well as it should be. And if you have too fast injection, you may miss the pattern, the enhancement pattern. Also, these should be 3 millimeter slice thickness or less, again, in order to catch those really tiny papillary projections. And this is also important. The temporal resolution should be 15 seconds or less, so that you're acquiring a phase every 15 seconds or less. So again, the first 1 or 2 phases is acquired before the contrast, and then the contrast is administered, and then you're acquiring at least every 15 seconds until 3 minutes. So here's an example of multiple phases going through and you can see the progressive enhancement of the papillary projection here. And this was a clear cell carcinoma. So this is a time intensity curve analysis. This is also very important to get correctly. So we have 3 different types of curves. And this is really to differentiate O-RADS 3 versus 4 versus 5 lesions. So we compare the enhancement pattern to the myometrium. That's also important. So in order to do it correctly, in order to get the correct answer or correct risk stratification, you need to perform the analysis correctly. So the way that we do it is to put a ROI on the myometrium here, and then also an ROI on the enhancing adnexal mass, and then plot those 2 curves simultaneously on the same graph. And then you have 3 different types of curves. You have the low risk curve, which is a slow gradual increase in enhancement over time, as opposed to the myometrium, which has this sharp arterial enhancement that that usually decays over time. But if you have an enhancement pattern that just gradually increases over time, that's a low risk curve. So these are O-RADS 3 lesions. If you have a upstroke or arterial enhancement, but the slope is less than the myometrium, then that's an intermediate risk. Sometimes these are almost the same. You're looking at the myometrium, and it even enhances more than the myometrium, but the slope is less. That's still an intermediate risk. And then the high risk curve is if the adnexal mass is enhancing faster than the myometrium. So really, between the intermediate and high risk, you're looking at the slope of this arterial enhancement. And for if you don't have dynamic contrast enhanced curves or enhanced sequences, and you just have that post 30 to 40 seconds after contrast enhancement, that's really, a single time point that's in the middle of this arterial enhancement. So that's why it's important to have it at that time point. So that's kind of the average time when the myometrium is in its upward stroke arterial enhancement. That's why that time point was chosen. So for MRI recommendations, for the O-RADS MRI recommendations, we look for the region of greatest early enhancement in the solid tissue. And this is found on the subtracted series. So you really get rid of any underlying T1 signal in the adnexal lesion, because the hemorrhagic material can also produce T1 hyperintensity, as we've mentioned before. And then we look at the first few phases to see which parts are enhancing the most. So you can see that here's the enhancing portion on the right side and on the left side as well. And so for analysis, this is kind of what we were talking about before. You put ROIs in the outer myometrium, because in the inner myometrium, there's lots of vessels that go in the uterus. So, and then also, you may not want to put it there because it's not as uniformly enhancing. So again, outer myometrium is the most uniform enhanced portion of the uterus. And then you put the ROI on the most enhancing portion of the lesion. And you also want to make sure you avoid fibroids, because those are also lesions, and you really want to just look at the muscle of the uterus. So again, we look at the slope of the initial rise. So this first curve is a high risk. So the first curve actually here, sorry, the myometrium is in blue, and the adnexal mass is in yellow. So this is intermediate risk lesion. So the slope there's a arterial enhancing lesion here, but the slope is slower than the myometrium here. So this is intermediate risk. And then on the left here, you can see it's very close, but if you look carefully, excuse me, the mass is actually enhancing faster than the myometrium. So in this case, we don't have a low risk curve. But again, there's no shoulder to the low risk curve, so it's just a continuous enhancement. So there's no shoulder there. So that's the difference between the low risk curve. So you can have to troubleshoot any issues. So only one curve is visualized, or the two curves may have very different baselines. So that's really, I think, a plotting abnormality. You really want to set your scale to absolute rather than relative or percent enhancement, so that they're compared on the same level. So that's something to keep in mind when you're plotting these So hopefully your PACS can do it. Otherwise, you could export these to an Excel to draw the graphs for you. So this is another issue that we talked about earlier, that T1 hyperintensity may not be enhancing necessarily. And so it's really important to use that subtracted sequence in order to tell which ones actually have enhancing solid tissue rather than any solid components that are not enhancing. And so this one is a non-dynamic. If you don't have DCE, I know it's hard to run these sometimes. It takes extra time. So if you only can run a post-contrast, single post-contrast sequence, again, it's really important to have it at that 30 to 40 second time period. And because that lands you right at that upstroke that we looked at in the curve, so we're able to compare the myometrium versus the adnexal mass there. And so if it's greater than the myometrium, so then when you draw the ROIs, you compare the outer myometrium again with the adnexal enhancing component of the enhancing solid tissue of the adnexal mass. If it's greater than the myometrium, then it's an O-RADS 5. If it's less than, then it's O-RADS 4. All right, let's go over some cases. I'm just going to pause there. Any questions before we jump into some cases? All right. So this is a 23-year-old female. There is a lesion here on the right adnexa. So this is T2, so it's T2 bright. This is without contrast. This is with contrast, but a subtraction, so no internal enhancement, but there is T1 signal. So which O-RADS MRI category is this? So in this case, it's an O-RADS MRI 1. So premenopausal hemorrhagic cysts. Oh, sorry, it should be O-RADS 2. It's a hemorrhagic cyst that's less than 3 centimeters. Sorry about that. O-RADS 2. Sorry, this is a little bit confusing. For premenopausal, this is O-RADS 1. For postmenopausal, this is O-RADS 2. So this is a physiologic lesion. Hemorrhagic cysts under 3 centimeters, corpus luteum under 3 centimeters. This is all just physiologic, ovarian lesions. All right. So what about this? So we have a T2 weighted sequence here, multiple septations here. So what type of solid component is this? So I kind of give it out. It's a smooth septation. There's no nodularity here and no papillary projections. So which O-RADS MRI category is this? So this is O-RADS 3. It's a multilocular cyst with smooth septations. So the low risk category for malignancy, about 5%. Malignancy, positive predictive value. So these include the hemorrhagic proteinaceous cyst, multilocular cyst, or solid tissue low enhancement. So in this case, for us, it is a multilocular cyst. And other O-RADS 3 lesions, as we can mention. So ours was just a multilocular cyst. It doesn't matter if there's any proteinaceous content. So these mucinous cystadenomas, or they can include these fallopian or like hematosalpinx also is in this category as well, or lesions with mildly thickened walls as well is in this category. All right. So part of the O-RADS 3 lesions are these any lesions with the low risk curves on dynamic contrast enhanced sequences. So again, we find the most enhancing portion of the adnexal lesion and draw an ROI on it. And again, we draw an ROI on the outer myometrium. And if the curve is just slowly enhancing without a shoulder, like this is the shoulder here, which has a upstroke and then flattening out of the curve, that's that shoulder, no shoulder here on the adnexa. So this is a low risk curve, which is O-RADS 3. All right. How about this lesion here in the left adnexa? We have a cystic component and also a T2 dark solid component. This is a high B value. You can see that there's some cyst there, but also no signal in this lesion here. But even though there's no or low signal in the DWI, there is some minimal enhancement here as well. So what is this? So this is T2 dark, homogeneously hypoenhancing. So it's not only T2 dark, it's DWI dark, dark. That's important to note here. So which O-RADS category is this? So this is 2, and this is actually a cyst adenofibroma. So if you have a cystic and solid lesion, you're really looking at that solid component to risk stratify that lesion. So here is the other O-RADS 2 benign lesions. In this case, we're looking at the fibroma, fibrothecoma. This is T2 dark and DWI dark. So this is dark. Remember, that's a fibroma or fibrothecoma. There can be cystic components also associated with it, and that's usually adenofibroma. So that's a important diagnosis to keep in mind because some of these can look a little bit more complex, but if it has the solid components are dark, then you can say that it's a more benign lesion. So other O-RADS 2 lesions are simple unilocular cysts that are greater than 3 centimeters. This is for premenopausal patients. Hemorrhagic cysts greater than 3 centimeters, dermoids, endometriomas, simple hydrosalpinx, and then we talked about the dark lesions or the fibroma, fibrothecomas. All right, so we have a lesion here with a cystic and also papillary projections. Here's a curve for that papillary projection. And what type of enhancement pattern is this? So we have the myometrium here, and then the lesion. So the lesion enhancement curve has a smaller or lower stroke than the myometrium, but there is a shoulder here, and it flattens out. So this is an intermediate risk curve here. In this case, with the intermediate risk curve, this lands it at an O-RADS MRI 4. And this ended up to be a serous cyst adenocarcinoma. So here's a different lesion here. The myometrium is this is a left adnexal mass. So we look at the myometrium. On the DWI, you could see those solid components really showing, or solid tissue really showing out. And then post-contrast here. So if we draw ROIs on these, you could see that the adnexal lesion has a faster or stronger upstroke compared to the myometrium. Even though the adnexal lesion is not enhancing as much or has lower final signal than the myometrium, it has a higher upstroke or slope compared to the myometrium. So this is a high-risk curve. And then O-RADS MRI category associated with this is O-RADS 5. So this one ended up to be serous papillary tumor. All right, so we looked at a lot of the parameters of sequence acquisition, which is really important to improve your evaluation, as well as to really accurately risk stratify lesions according to the chart, the O-RADS MRI chart. We really need to perform the right protocol. Each sequence has its strengths and weaknesses, like the T2 really is our anatomic sequence. Make sure that we have the 3 millimeter slice thickness to find all those small papillary projections. And it's really robust in artifacts, but DWI and enhancement are better equipped to kind of get the functionality of those adnexal lesions. So you can tell what is enhancing solid tissue, which is important to identify, so that those are usually the more worrisome lesions. So we also talked a lot about troubleshooting artifacts and understanding pitfalls, and then went over some cases. So I'm happy to take any questions that anyone may have.
Thanks a lot, Angela, for delineating, especially the protocol was very beautifully explained. There are a few questions, and I think we have some time to answer them. So let's actually start with the questions related to the protocol, because there are a few of them. So you talked of a temporal resolution of 15 seconds and the need to take it till at least 3 minutes. So then one anonymous attendee is asking, overall, how many contrast acquisitions should we take on the dynamics?